Whenever you're ready.
Okay, so the journal article I'm presenting is the neurodevelopmental outcome at 2 years of age after general anesthesia and awake regional anesthesia in infancy with a gas study. It's an international multi-center randomized controlled trial. They published their data. This is in 2016. I don't know why there's no date on there. So the background, why do we care about this or why do we need this, is that there is animal data. There's a lot of animal data, and it does show that general anesthesia shows changes in brain development in young animals. They show it in all general anesthesia medications. It doesn't matter, it's not just ketamine, it's not just Evo or propofol, it's all of them. In the animal data, again, it shows that it's greater with longer exposure, but the problem is we don't really know what the significance is in humans. To date, even to this date, there is no randomized control trials in humans. The data that we have is all retrospective and it's conflicting. Most of it shows that there's not much difference in general anesthesia to not having general anesthesia, and some show that with more exposures there is a difference. And in the human studies, they believe that a lot of confounding actually restricts any assumption of causality. So in other words, there's underlying pathology, there's comorbidities, perioperative risk factors, because why are these children having surgeries? So in April of 2018, anesthesiology devoted several entries in this in the April one for pediatric anesthesia. One of the review articles in here was about exposure of developing brain general anesthesia, and this is just all about the animal data. And so they comment on rodents being exposed to 3, 4, 5 hours of anesthesia, but remember the rodent has a shorter lifespan and the brain develops much faster. So it's basically like giving them weeks of general anesthesia. And then the same thing, again, how can you translate this to humans? Because they are anesthetizing healthy animals. So all their animals are getting general anesthesia, but again, with the confounding on the humans, the children that are getting anesthetized, most of them are sick, or there's a reason why they're getting anesthesia. Again, this is all in the April of anesthesiology. This is where the previous studies, notice that they're all retrospective. And this is using a main outcome of either school readiness or performance at school. And if you notice, most of them, though it's difficult to read, there's really no difference. Same thing, all retrospective. But now if you look at other studies, again, mostly retrospective, and you're using a diagnosis like ADHD or some kind of emotional diagnosis, there you can find some outcomes in these studies, but for the most part, again, it's we have some that show some differences and a lot of them that don't. And you'll notice all the way at the bottom, Davidson in 2016 is the only one that's randomized. It's a randomized trial. So that's why this is significant. That's why I'm presenting this article right now, because it's the first randomized trial. So what is it? They're comparing sevoflurane to awake regional anesthesia for hernia surgery in early infancy. The primary outcome is having this WPPSI-3 full-scale intelligent quotient score at age 5. So this will be available next year. So we'll find out if there is a difference in general anesthesia to not having anesthesia. What was presented in this article is the secondary outcome, and that's the Bailey-3 at age 2. It's observer blind, so that's the test that is given at age 2. They're blinded to this. It's international. It's multi-site. There's 28 hospitals. It's randomized, controlled, and it's equivalence trial. Is there a difference or not? That's all what they really want to see. They're taking infants up to 60 weeks post-menstrual age, but they had to be greater than 26 weeks gestation. And they're excluding a lot of children that if they have congenital heart disease, they had surgery or meds, mechanical ventilation, chromosomal abnormalities, if they had previous exposure to general anesthesia, if they had known neuro injury, and then if there's going to be a follow-up difficulty, they'll exclude them. And that would be if, like the Bailey 3 test or the test at 5 years of age, if it's not given in their language, then they couldn't enroll them. So let's say they only spoke Swahili and it doesn't come in Swahili, they excluded them. Randomized. They randomized them in blocks 2 to 4, stratified by site. They divided them in 3 gestational ages. Of course, the anesthetist was aware of the allocation. The parents were unaware, but they were told if they asked. And the pediatricians and the psychologists did not know whether they were in the general or the regional group.
I got code yellow.
So this is the trial profile, and it's hard to read, but you can read it in yours. But they started out with 4,000. They screened 4,000 children, and they made it down to, basically 200 and some change in one arm and almost 300 in the other arm. For the awake, they got spinal caudal or combined spinal caudal. They used bupivacaine or legal bupivacaine, depending on what country you're in. Ilioinguinal and field blocks are allowed. They were given sucrose to suck on during the procedure. And if they required sedation, it was considered a protocol violation, so then they were excluded. The general anesthesia was sevoflurane only. You could use Elevate, Intubate, you could use neuromuscular blocking agents, so it was totally up to the anesthetist. Air and oxygen only, no nitrous oxide, no opioid. They had, you could have a caudal for post-op pain, ilioinguinal, iliohypogastric, or field blocks. Those were allowed in both groups, and both groups also could have oral and IV Tylenol. They measured, among everything else that's measured that we monitor, they also measured glucose, and so if there was hypoglycemia, they had protocol for that. Hypotension was fluid bolus, and hypoxemia was oxygen by face mask. Here's the test. The test is a validated test, but and given at 2 years of age, plus or minus 2 months. It was given by a trained psychologist. The main outcome was the cognitive score, and it measures attention, memory, sensory motor development, exploration, etc. Also language and motor scales by Ambrose. The parents were given a questionnaire to fill out, so this was the subjective portion of the exam. And at 2 years and at the beginning, they measured, they collected demographic data, family history, medical history. They did a physical, and then they did a brief neuro exam. So the main outcome of this was the composite cognitive score of the Bailey-III test at age 2. Secondary outcome were the other components of the test: language, motor, socio-emotional, adaptive behavior. Again, this is an equivalent study. The outcome analyzed on an as per protocol basis, so those that actually didn't break the protocol, which is conservative, what the author's saying, so that they would be able to find if there was a difference, err on the side of finding a difference. And then they also looked at the intention to treat data, those that did violate protocol, but just to see if there was any type of differences. Sample size, the sample size was based on 5-year follow-up, so based on the data that they're going to get, that they're going to present next year. So that was roughly 600. They enrolled 720 and allowed for the 10% dropout and 10% protocol violation. Results. So evidence for equivalence in means between the awake regional and general anesthesia groups in both. The as per protocol intention to treat. So they basically said it was equivalent. There was no evidence for difference in the MacArthur-Bates scores. And they did some worst case imputation for the missing data. And again, they were saying by doing this, they would err on the side of finding a difference. It made it sound like that was conservative. Again, strong evidence. They're saying because of all their data, there's strong evidence for equivalence between awake regional anesthesia and general anesthesia in infancy in terms of neurodevelopmental outcome at 2 years of age. 90% confidence interval, fell in the third of standard deviation. Again, this was the first randomized trial. There were no previous randomized controlled trials, and all the previous retrospective studies showed mixed results. They did look at the the kids that scored below 2 standard deviations in both groups, and they didn't find much difference. And I don't know why they mentioned this, but they looked at children with autism, CP, visual and hearing defects, but they said this, there wasn't many infants in these groups, and so it wasn't powered to really find out anything about these problems. The median sevoflurane exposure is 54 minutes, so that is relevant because most pediatric surgeries are less than 2 hours. So it being 54 minutes means it's relevant, and we can actually translate this to all the pediatric surgeries. In some preclinical studies, some animal studies suggest that prolonged exposure to general anesthesia is necessary to show injury. Or are there multiple exposures versus a single general anesthetic that will show something? This study can't comment on any of that because, again, it was only 54 minutes. We cannot rule out the possibility that longer exposure or multiple exposures might have an effect on neurodevelopment. Again, they looked at the attention to treatment as per protocol, and they said there were no differences. The Bailey 3 test is validated, but since neurodevelopment occurs much later, they figure by 5 years, it still is too early to be a definitive saying that there's no neurodevelopment effects after general anesthesia. So in other words, here they're saying that this study, that it wasn't powered for the secondary outcome, which is the outcome of this study, but it is powered for the primary outcome, which is at 5 years of age. In this one, most of them were male, most of the infants were male, and that correlates with a lot. Since in the animal studies, the male animals showed more changes in neurodevelopment than the female, they thought, okay, well, this is good. We can use this data. And the only thing that's, like I said, that was qualitative would be the MacArthur-Bates score, because that was dependent on parental report, and that was open to bias. So again, this was the secondary outcome. They received less than an hour of general anesthesia in infancy. It doesn't increase the risk of adverse developmental outcome at 2 years of age, is what they're saying. But although they're saying it's not definitive until we come out with the data from the at 5 years of age. I put this in, there's a Smart Tots consensus statement. I figure, even though not everyone in here is pediatric anesthesiologists, you have friends that have children, you have children, and everybody wants to know. So this is the statement from the Society of Pediatric Anesthesia, Smart Tots. Then they also came out with a supplement to it, just saying really try to delay surgeries if they're elective, discuss everything with your physician, your surgeons, and then And then the FDA gave a warning in October of 2016 saying that based on animal data, anesthesia can affect neurodevelopment. Now the authors, I looked back, I was reading some of the articles in the 2018 anesthesiology. They don't like, this is based on animal data, it's not based on human data is what they're saying. There's more, it's by saying that it can affect neurodevelopment is probably a little premature since we really don't know. They were talking about, remember when people talked about compound A and sevoflurane? That's a thing of the past. We told everybody that there's possibility of you getting, it's nephrotoxic, and now, you know, the FDA put out that warning, but it's untrue. And we're hoping that maybe this will be the same thing, although for short, one single general anesthetic, but maybe not for multiple. That's it. Yay. I don't know if anybody else read the article.
You said that they recommend delaying elective surgeries till what, after 2 years of age, or?
I think after 3 years of age.
Three, okay.
You know, they talk about these things that a lot of these are not. In the consensus statement, it talks about the different surgeries that need to be done, you know, heart surgery, cleft palate, so you can't delay certain procedures.
You can delay circumcisions.
Circumcision, I think that might affect our urologists.
Yeah.
Yeah.
Although the short, under 1 hour cases, they think there's not effect. I mean, I guess we're
Yeah,
gonna find
I
out
know.
more.
But right now they're saying no. And a lot of the previous studies are pretty much saying the same
Right,
thing.
exactly. So a circ is a quick thing.
And when you talk to the urologist, they say that it's better to do it early. Like that's their
I mean, if there's phimosis, you have to do the procedure.
correct. But like to fix a circ or
Yeah, to an imperfect penis.
yeah, they'll say, well, it's better for the child to do it early and it's short. So
But we're doing some of them at 1 month and 2 months, which I think is not necessary. I mean, 6 months, at least you get your liver is more developed and, you metabolize things
I don't
more.
disagree, but what do you say?
Why are we doing the ones at 1 month? Just because they didn't want the obstetrician to do it? Is that the reason why? Or was there a problem? I think there
They
was a
just did
problem.
one, right? Why? You know. Okay.
Maybe because they get no anesthesia at birth.
They do.
They put EMLA on, but
Yeah.
that doesn't
Well,
work.
I think some people delay it because they want a urologist to do it. And then, urologists don't want to do it after a few days because they're too vigorous and move, with just local or whatever.
Well, they don't use the bowel.
Yeah, they won't do it because they're just too awake and vigorous. Whereas right after birth, they're kind of sleepy.
And same thing with some of these 2-week-old brain MRIs.
Oh.
Like
Yeah.
Some of those are not.
Well, those are, there's a reason.
The
they're done.
MRIs are the ones I really worry about.
Yeah.
Because so many times they seem so sketchy. Those can be really wrong.
And a lot of those actually can be healthy, so I thought we could compare people, babies that got MRIs. Basically no reason,
Although the
compare
brain
them to.
ones, there's something neuro.
Because they have seizures.
Something that they suspect neuro, so. The scan is short, but they're there sometimes for a reason. Sometimes just because they have a pulse.
I don't know, very few parents ever ask me about this, which I find surprising. And then when they do, I tell them the answers, and I've never had anyone want to delay. I've never had anyone say, well, after hearing this, maybe we should wait for this elective case.
Well, what do you tell them?
I tell them a long story short is we don't know.
Right, that's what I tell
But
them too, so. if we
but I
don't know-
say animal studies show that there is neuro delays in young animals that get anesthesia. But then I say, but they get ridiculous amounts of anesthesia, and they get multiple anesthetics. So there's no real proof that this correlates to humans. There's ongoing studies that are out there that suggest that it's probably not true that this causes neurocognitive defects. And the question is this just the natural development of the child, because whoever's getting the anesthetic is usually, or multiple anesthetics, is sick, versus is it the anesthesia? And we don't know the answer to that. And most parents are look at me confused, and then I tell them it's like, do umbrellas cause rain? Because if you go outside when it's raining, there's lots of umbrellas. But that doesn't mean umbrellas cause rain. It just means when there's rain, there's lots of umbrellas.
Well, I think.
You know what I mean?
I think